Okay, so thank you, Rabbi. And it's an honor for me to speak in front of you. What I will show you now is the normal fetal face and the benefit of 3D on the examination of the normal fetal face. When we do 3D, we save a volume. That means the probe will do only one sweep, and after this sweep, we obtain a volume, and we can work inside this volume. We can do any section plane inside, and we work most of the time on a multiplanar view with on the E plane, B plane, and the C plane. And when it's done, you can also apply a rendering, so you have the 3D rendering of the face. And this is 3D, that means you do only one sweep with a good quality, but we can also use a 4D. With 4D, we have a continuous sweep of the probe, and you have a 3D real time. But it's not a really real time, because with good quality, we can go to 5 volumes per second, 2 to 5 volumes per second. We can move to 20 volumes per second, but the quality is not good, and you have to choose a small box. If you want to do a 3D of the fetal face, what we will use a surface mode, and for this we need amniotic fluid. If you have no amniotic fluid in front of the face, it's not possible to do it. So you need to start with this, the baby in this position on 2D. If the baby is in this position with a placenta in front of the face, it's not possible to do a 3D of the fetal face. What you have to do is to move the baby or to wait. We have different kind of acquisition, the position of the probe. What is more easy to understand is this one. You start with a 2D of the profile on 2D, and the probe will do a sweep from one side to the other side, and the result is this one. But it's not so easy to obtain because you need amniotic fluid in front of the face and also on both sides. But this is a perfect acquisition if you want to do the assessment of a cleft lip. What I prefer to do this acquisition. This is an oblique acquisition. You start from the visualization of the nose and the lips, oblique here, and you will obtain this. You can apply different rendering modes. We have different algorithms, and you can see here surface texture, gradient light, and you can mix. And the best, which I use the most often, is this one, is mixed with the gradient light and the texture. Is it easy to do a fetal face? This is my result. I always try to do a 3D during my 2D examination. I don't need it, but it's the best way to train. So in the first trimester of the pregnancy, this is the number of examination, and I succeed to obtain a 3D in this number of examinations. That means the success rate is 86%. In the second trimester of the pregnancy, it's 92%. Why? Because you have a lot of amniotic fluid in front of the face, and if the face is not in the correct position, you can move the baby. And during the 20 minutes of examination, you will have the face in the correct position. Third trimester, it's more difficult. I have my success rate is 77% to obtain the fetal face. Why? Because sometimes, first, you cannot move the fetal head. It's really difficult. And you have no fluid in front of the face. So on my lecture, you will see many pictures like this. This is a profile, and when you look at this picture, maybe you think it was a baby with lots of amniotic fluid, but it's not. It's only, I will give you my trick to do this, I only remove half of the face. And this is exactly the same baby, this one, and this is after using the magic cut, the electronic scalpel, and I will show you how to do it. First, I will remove what is in front of the face. So this is a magic cut. Now I will cut a part of the forearm. Now the profile, but on the background you have something. So if you want to remove it, just put the face from en face and you have to cut half of the face, and after cutting half of the face, you have the profile with this black background. And this is the best if you want to study the facial morphology. So with 3D, we can see the baby with lots of different attitude. We can do it also with 4D. And you can see on all this video, it's not real time because we are around 2 to 5 frames per second. But if we try to obtain a high frequency, more than 10 to 20 frames per second, the quality is not good. What is new on 3D? Until last year, it was not possible to change the position of the lightning. That means the direction of the it's the same with the digital camera. The direction of the shooting and the direction of the light are the same, like this. But if you want to do a nice picture of somebody, you have to move the position of the light, and this is possible now with the new mode. The name of this mode is HD Live. It's a new render mode, it's a new surface mode, and also you can change the position of the lightning. This is the same face with two positions of the lighting. One is coming from here, and the other is coming from here. And you will see in real time how it's works. You just have to click on the trackball, and you move the position of the light. And this is the same face, one without moving the position of the light, here, and different position of the light. Most often, the best position for the light is on the upper part of the head. So we obtain this kind of picture, but it's quite difficult because you always, for each baby, you have to change the position of the light. So when it's done, I always work with a classic 3D, and when the volume is clean, I press the HD Live button, and I have to move the position of the light. And we can also do it with 4D. And this one, yawning and opening eyelids. So when I start to use it, I asked the patient what was their opinion. First, what is your opinion with this new rendering mode? It seemed more real, it looked like wax, it's softer, it looked like a doll, okay? And which one do you prefer? But it was not 100% to the new one. It was 65% for the new mode compared to the old mode. So I asked, why do you prefer this new HD Live? Because it's more real. And for the other, I asked, why do you don't like this new HD Live? Because it's too real. This is the problem. But it was the same with 2D and 3D at the beginning 20 years ago. Lady didn't like the 3D because it was too real compared to the 2D. So we can see all the part of the fetus, and especially we can highlight the eyelid, philtrum columns, cupid ball, white skin roll, and all the part of the fetal face. And this is a benefit. I will show you one case of Down syndrome. This is a Down syndrome, and we did the diagnostic because of other malformation. But what you can see on the classic 3D, the width of the mouth do not exceed that of the nose. That means normally the mouth is large and more than the size of the nose. But using this new HD Live, you can highlight the up-slanting palpebral fissure. You can really demonstrate it. And here you have 4 Down syndrome with exactly the same aspect of the eyelid. And also look at this one. This was a Down syndrome, but also with a cleft lip. So when we have a cleft lip, we always want to know if there is a cleft in the palate. So I always do it step by step in case of cleft lip. First, I want to know if there is a cleft lip. For this, I will use 2D for the screening. After, I will use 3D for the external part of the fetus, cleft lip. And after, step by step, I go in depth. I try to see if there is a cleft in the alveolar ridge, a cleft in the primary palate, and a cleft in the secondary palate. What you have to do if you want to use 3D, you have to do a correct acquisition. You have to work with a perfect volume. You don't have to start with this position, because if you start with this 2D position, when you do the scan, the sweep, it will be from one side to the other side, and you have here shadowing, and you will have this shadowing inside the volume, so it's not possible to work with this. The best method is to start with this position, but the head is tilted back, and you have to put the probe exactly in this position. But it's really not easy to obtain. Sometimes you will spend 10 minutes or 20 minutes to do it. So you will do it only when you suspect a cleft palate. But this is not a screening method. It's too difficult. But when it's done, you obtain this. You can move inside, obtain a nice view of the complete hard palate, and this is the palate, this is the alveolar ridge, and this is the posterior edge of the palate. What is important, it's really the quality of the volume. When you have this, you can use the frontal view. That means here you look at the face from here. This is a rendering of the green line with the palate. Also, we can use a reverse view from the back. And also this one is a flipped view, and you look at the palate from under, and you have this. You can use all this method. It will work only if you have a nice volume. If the volume is not correct, it will not work, and this one will not improve the quality of volume. Also, what you can do any section plane inside. You can do section, line, and also curve. This one in yellow is this with a complete palate, and this one is the green one, and this one is a pink one with the alveolar ridge here in the front. But this is too difficult, in my opinion, to use it, and we cannot use it for screening examination. The best, if you want to do the screening examination of the palate, is to do it with 2D. What you have to do, you have to put the probe, the ultrasound beam of the probe, inside the mouth, between the mandible and the maxillary, and you will try to find the intersection between the ultrasound beam and the posterior edge of the palate here. How to do it? You start from a profile view, turn 90 degrees, you will find the two orbits, and now you will try to find the mandible, maxillary, and you tilt the probe, and you have to tilt slightly the probe, and you will find the posterior part here of the hard palate. So this is a method. This is quite easy to do it, and this is a good screening method. You will have other method later on other lecture, but this is easy to do if the face is looking up. And from here, also you can do acquisition on one volume, and this is a volume obtained here. You have the shadowing of the maxillary and the mandibula, but moving inside, you move from the alveolar ridge. This is the tongue, and here, the posterior part of the hard palate. And you can use a polyline OmniView to do the rendering of the alveolar ridge and the complete palate. What we can see on normal pregnancy, 9 weeks of pregnancy, you cannot see the face. It's too difficult because the face is completely banded on the thorax, and it's difficult to identify. But I just put this picture to show you what is the first bone to appear in the skull. Do you know which one? It's this one, the mandible. This is the first ossification of the skull, is the mandible, seen with ultrasound. Now, some example of fetal face in the first trimester of the pregnancy. what is typical in the first trimester of the pregnancy, you have a large head compared to the body. The ears are in a low position, and also what you can see here, you have a notch on the posterior part of the ear, and this is normal until 13 weeks. We can use maximum mode. With the maximum mode, you can see the bone inside the volume. This is exactly the same volume with surface and with the maximum mode. And sometimes we use it to demonstrate, in this case, the absence of nasal bone. Here you can see the nasal bone and absence of nasal bone. And don't forget that when you do a volume, you can use this volume with a surface mode, but also you can do any section plane inside. This was a nice volume at 12 weeks of pregnancy of a fetal face. And you can do all the sections. This is a section with the two orbits, the two ears, and this one with the maxillary. And this one, is it the palate? It's not really the palate because the section is here. This is a vomer. And this is a mandible, and at the beginning of pregnancy, you have a typical shape of the mandible with a narrow angle, and you can compare with the mandible at 22 weeks of pregnancy. It's completely different. And this is important because in case of Pierre-Robin syndrome, in case of severe retrognathia, this is a normal mandible at 12 weeks of pregnancy, and this was a case of Pierre-Robin syndrome. The length of the mandible is normal, but it's round on the anterior part, and it's not the same shape you can compare. With the aspect of the face, we can tell if it is a first trimester, second trimester, or third trimester pregnancy, because it's completely different. This was around 15 weeks of pregnancy. This is late on pregnancy, and this one is a 22 week of pregnancy. You can see here, this is at 22 weeks of pregnancy. In the third trimester, the baby is more chubby, you can see here, and also it's more easy to see the eyelid. It's not possible to see it at 22 weeks. Why? Because you have a slight exophthalmos. This is normal at this stage of pregnancy, and the fetus cannot open the eyelids because it's stuck. And you saw my case of Down syndrome. I show you with the position of the eyelid, and this is worked perfectly, but unfortunately only late in the pregnancy, in the third trimester, because in the second trimester, it's really difficult to see the exactly angulation of the eyelid. But this is not only pretty picture. Here you have picture at 32 weeks of pregnancy and compare with at birth. It's really close to the reality. And I like this profile view, especially at 32 weeks when it's possible to do it. And you can see all the baby are different. Some are nice, others are not so nice, but this is normal. But it's really difficult only with the profile to do one diagnostic. You have to use other marker. And look at this. Here you have 10 fetal face and 5 Down syndrome inside. Are you able to tell me where are the Down syndrome? We will do it step by step. This one, is it a Down syndrome? No, it's a nice one. Okay, this one, yes, it was a Down syndrome. This one, no. It was not a Down syndrome. And this one is nice, but it was a Down syndrome. But why we did this diagnostic, it's not only with a fetal face, it was a baby with atrioventricular septal defect, with a short femur and mid ventriculomegaly. And this one is a normal one. This one, Down syndrome. This one is a normal one. This one is a Down syndrome. And this one was a Down syndrome with a cleft lip. But the cleft lip is on the other side. And this one was a baby with a flat face and with a short femur. We did amniocentesis for this, but it was normal karyotype. And the last one is a Down syndrome. What's about the ear? You saw it in the first trimester with a small ear in a low position, and this is a round ear at 22 weeks of pregnancy, and later in the pregnancy, in the third trimester, you can see all the fold of the ear and also the hairs. Different aspect of normal ear and two abnormal ear, and this one was a Down syndrome with a fold of the upper part of the, and this one with the abnormal fold of the ear. So when we look at the face, we always have to look at the external part, but don't forget if the fetal face is abnormal, maybe there is something wrong with the skull. So you have always to study the skeleton, and the skeleton, the skull. It's not difficult to do it. We will switch to the maximum mode. With the maximum mode, we can see all the bone inside, and we can see all the bone and all the suture inside the face. And this is, here you can see different face. It was a fetus with lots of malformation, with facial dysmorphologia. And with 3D, you can see here one with abnormal metopic suture with K-hole shape, this one with additional bone in the metopic suture, this one with hypoplasia of this frontal bone. It was a baby with microphthalmia. This one with a large open metopic suture, and this one hypoplasia of this frontal bone, and also a cleft here. And this was a baby with a head with a craniosynostosis, and because of this bone inside the fontanelle. So the main advantage of 3D is not when the baby is normal, but it's when you have a malformation, because you can suspect it with 2D ultrasound, but with 3D you will demonstrate it, you will prove it. So thank you for your attention.